details in this by the MS39. I can say that from 1 year ago, I didn't use Pentacam or other devices. Now, my beloved and my trustable device is the MS39. Actually, I'm a refractive surgeon and a cornea surgeon as well. I'm the head of the refractive unit at Al-Azhar University, Cairo, Egypt. So let's start now to say Bismillah ar-Rahman ar-Rahim, Assalamu alaikum wa rahmatullahi wa barakatuh. Peace be upon all of you everywhere. Let me mark it now to share my screen to start my presentation.
You should do, yes. Okay, perfect.
Tell me when it's visible. I think I'm audible and my voice is clear, right?
Yes, I see your screen. Perfect.
Yeah, it's overcrowded the screen, so I will try to find my presentation. Now, yes. Yeah, finally it's here. The talk today about the state of the art with MS39 anterior segment OCT corneal mapper. We will discuss briefly clinical application of this device in cornea, cataract, and refractive fields. Actually, no financial interest for this presentation. Regarding the old devices used for getting topography and tomography for the cornea and prior to doing refractive surgery, we have a lot of machines with different mechanisms like Galili, Pentacam, and Cirrus, including the slit scan and the Orbiscan, or the Scheimpflug camera, or the dual Scheimpflug camera in the recent. Excuse me, can you mute all of them, Marco? Please ask all audience to mute themselves. But having the topography by the Placido-Desk or by the slit scanning in the Orbiscan or by the slit scan also in the Pentacam, adding to this topography, the tomography maps obtained by these devices, but in some cases, we were still suspicious and we were still worried about if going for refractive surgery or not. And actually, after the era of the epithelial mapping, we started to send for epithelial mapping using the anterior segment OCT by the OCT devices. But nowadays, after having this device, which is a combo, which is a combination of both Placido-Desk to get topography, the OCT-based tomography, also the epithelial mapping by the OCT, the high-resolution OCT. Now, I don't need any other machines to decide about my patient. So it's a great combination if you have it in your center. The components of the MS39 is the Placido-Desk and the spectral domain high-resolution OCT, and I will be somewhat fast because of the sake of time. So what they offer for us, Placido-Desk gives us a better and sensitive imaging of the anterior corneal surface, anterior curvatures, and refractive powers of the cornea, as well as the tear film analysis, as I will show later. Also, the spectral domain high resolution OCT, which is highly accurate measurements of the corneal elevations, epithelial and stromal separate mapping, as well as accurate study of the whole anterior segment. So I'm talking about precise device with precise aids. The technical specifications, it's a matter of physics and some elimination ranges, but I will not take the time in this. The resolution is, an axial resolution is 4.8 to 3.5 microns in air and tissue respectively. The transverse is 35 microns. Also, the maximum scan range, which is different than the other devices, up to 16 millimeter, which will cover the whole cornea, limbus, and part of the sclera. the light source in the Placido desk, also in the OCT target is a consistent lit light with very fast scan. And I would like to tell you about how it's very fast scanning device, which is so helpful in children. Actually, I got captures for a baby of 3.5 years to decide if there is anterior segment depth enough, anterior segment depth, which is enough for putting ICL in case of severe anisotropy or not. The mean here that I get a capture for a child or a baby of 3.5 years old, which is very, very difficult to have it on another device without general anesthesia. So the functions of the MS-39 are the anterior segment OCT corneal mapping topography and tomography, the anterior segment OCT section for anterior segment like the chamber and posterior chamber features, the vault of the lens. Also, it's a very sensitive and accurate biometer, as I did a lot of biometry cases on it and compared it with the IOL master to find that they are almost the same. But I need to add axial length by the A-scan or other machines to complete the biometry process. Also, program, I can measure and study the pupillary movement and behavior. It's a very sensitive pupillographer, giving me this photopic, and mesopic, and finally the dynamic pupil, which is crucial data used for the refractive surgery, for the intracorneal ring segment, also for the patients going to implant for them a multifocal IOLs. The fifth function is the tear film analysis, which is very helpful, as I will show later. Glaucoma profile summary, and finally intracorneal ring segment implantation assistant planner. So the maps which we can obtain by this device are actually more or less 17 maps. The corneal pachymetry, corneal, stromal, and epithelial. It studies the corneal thickness in a very separate manner. The whole cornea, then whole stroma, and the epithelium alone. Also, the anterior and the posterior curvature maps, sagittal and tangential, which will be very helpful to diagnose the early cases of changes if we are going to be on suspicion. Elevation, anterior and posterior elevation with correlation to each other, also studying with the normative data for the age groups. Wavefront analysis, also the visual acuity simulator by the Zernike software to it's studying the total corneal high order aberration. Also, what's new in this device, the epithelial high order aberrations, to know if this high order aberrations are related to the whole eye or the whole cornea, and finally if they are related to the epithelium, to manage every layer alone and to choose if you need to do a correction at the level of the stroma, or even you can treat on the surface if you have epithelial high order aberrations. Refractive equivalent powers, anterior and posterior, and finally the Gaussian curvature maps. Also, the anterior and the posterior Gaussian maps, they are like that of the Bellin Ambrosio or the BAD display and the artificial intelligence softwares in the Pentacam. It's almost like that, because in the Gaussian maps, the astigmatic effect on the corneal elevations and the corneal map, they are totally totally canceled. So you will see the irregularities as a normal irregularities, not by the effect of the astigmatism in astigmatic cornea. Like that of the best fit ellipsoid, toric ellipsoid, instead of the best fit sphere, to know if they are related to the astigmatism or not. Let's go. So what's new in the MS-39? Simply the perfect combo, the perfect complementary combination. You will be confident cornea and refractive surgery if you have both together the highly accurate pachymetry and tomography. Actually, it is changing the map. Separate studying the corneal stroma and epithelium, also detailed corneal screening, and I will show later the very meticulous and detailed examination of the anterior segment. So it's called now the New Century slit lamp. If you have the MS-39, so you don't need to get a slit lamp. Yeah, I'm saying that by the use, or I mean that it's practically in my day, I can examine the patient with a MS-39 as if I'm examining him with a very accurate and microscopic slit lamp. So it's called the New Century slit lamp. Tear film analysis, which is very helpful tool for diagnosis and follow-up of dry eye, especially if you are examining a patient for refractive surgery to know if it's candid or not. A very accurate biometer, as I said before. Finally, an accurate phakic IOL planner, because it gives us the customized and certified measures. And here I have to stay for some seconds to mention an important point, which is the white-to-white measurement by this MS-39 is the most accurate. So I don't need to caliber or to measure by the other device. This is the point. The second point, when I send the measurements of the MS-39, I tell the company which will provide me the ICL that it's actually a customized internal white-to-white. No need for reduction, because they are reducing around 0.3 or 0.5 millimeter from the given white-to-white by the machines. But because the MS-39 is measuring the internal white-to-white, so no need to reduce any part of the given white-to-white. So let's go for our our core of the talk, which is the clinical surgical benefits of the MS-39. The ocular surface application, the corneal surgeries application like intraconus and intraoplasty, anterior segment studying for the phakic IOLs in the cataract surgery, glaucoma, and finally the refractive surgeries with its different fields. So firstly, the Placido disc, it offers a topography and tear film analysis. So I can study the ocular surface even by the Myers of the Placido disc. I can diagnose the keratoconus. Also, I can diagnose dry eye and irregular or unstable tear film or turbid tear film by the movements of the Placido disc themselves. And as you see here, the Placido disc in the photo on your left side, there is a very fast and very concentric circles of the Myers here, immediately down to the center, which is in cases of keratoconus. Also, on the left side, you will find that there is a narrowing of the Myers while they are moving around the inferior part, immediately down to the center. And down, you will find that the OCT, the corneal OCT, choose the thinning of the cornea in this center part, which is signs of keratoconus. Secondly, the tear film analysis. Also the MS-39 studies the tear film by measuring the bud time, the breakup time, by moving into 3 steps to know when the patients cannot tolerate opening the eye and he has to blink. So it records this time to define the breakup time, which is very important to know the stability and wetting and coverage of the tear film onto the corneal surface. It's important for diagnosis of the dry eye itself, and so no need for other diagnostic tools for the dry eye. It simply it can be done by this device, also by the Schirmer test, as we know. Also the breakup time by staining of the cornea on the slit lamp, no worry. But if you have it on the same device, it will be much easier and much helpful for the correlation. Here you find the maps of the anterior surface showing the damaged part of the tear film on parts of the cornea on certain time to conclude at the end about the breakup time and consistency and stability of the tear film. Like this case, here you will find that there is a red sign, the break time, on the different parts of the cornea, peripheral, mid-peripheral, and central part of that. The red sign showing less than normal a breakup time in this patient, which who came to our clinic for refractive surgery. So when I detected this instability of the tear film, I postponed the refractive surgery for her to treat first the dry eye to avoid the exaggerated dryness after refractive surgery. Also in this patient, you can see the irregularity of the anterior surface, but the back is very well. Also the regular epithelium. This patient clinically showed multiple corneal opacities with a subepithelial fibrosis due to severe case of trachoma and pannus in the superior cornea with subepithelial fibrosis all over the cornea with irregular surface. Actually, but unfortunately, I don't have the captures. On the Pentacam shows severely irregular surface because the Scheimpflug camera is blind in front of the corneal opacities, even if they are faint opacities, but the OCT can pass through the opacity with no effect, but will show the irregularity in the surface. So it's much smoother on this device than the Pentacam, but here it's obvious that there is irregularity in the central part of the cornea, also in the corneal epithelium, in the epithelial thickness. Let's see the tear film analysis of this patient to find that there is a red signs, which means that the breakup time was at 1 second. And you know that below 10 seconds will be abnormal. It's here severely abnormal. The second important application for this device is the anterior OCT section regarding the cornea studying. We need to study the cornea by the anterior segment OCT to define the corneal integrity, to know the epithelial thickness, and to know the flap thickness after LASIK, like in this patient. If you are gonna do any redo on the flap, you have to know the epithelial thickness, the flap thickness, and you will calculate the ablation depth not to exceed the allowed flap thickness. Also in the corneal opacities, you will need it to define the depth of the corneal opacities. If they are could be treated by the PTK, or you have to do a lamellar keratoplasty, or if the opacity is affecting the whole cornea, so this patient won't be candidate for the lamellar keratoplasty and will be for PKP. All these issues, you will get these all benefits from the MS-39. I will show clinical cases as I told you first, to apply them practically, not to talk about this device theoretically. This patient is 35 years old patient. She was undergone LASIK surgery with some of other colleagues, and came to my clinic complaining from corneal opacity and drop of vision. And she said, I didn't improve after LASIK. I didn't get any improve in my vision after LASIK surgery. And despite of the full treatment of steroid, she was diagnosed first by her surgeon as DLK or flap inflammation or bed inflammation, and all the differential diagnosis. And she was on steroid for more than 2 weeks with no improvement, but even she is getting worse. So when I thought, I saw her on the slit lamp to find that there's total corneal opacity with marked corneal edema. I couldn't define the depth of the edema. I couldn't define the cause actually of the opacity and drop of vision. The tension was very well, so I examined her with the MS-39 to find this surprise. Actually, the post-operative edema was not stromal edema, but actually it was IFS. You know, the IFS is the interface fluid syndrome. So there is the flap entrapped in the space between the flap and the bed with no absorption. So it's entrapped fluid, giving the picture of the corneal edema, giving the picture of the flap edema and opacity with no definite diagnosis. So when we diagnosed her with this anterior segment OCT and in MS-39, we actually knew the cause, so we can do it, or we can solve it by doing wash, lifting the flap, going to wash the bed with steroid and antibiotic at the same time to avoid infection, and then reposition of the flap. And in many cases, they will respond within 1 week or 10 days after that with a complete resolution, which will take some time in the chronic patients. And I sent her actually for her surgeon to respect each other with this anterior segment OCT to know the diagnosis. Other clinical case post-DALK. Actually, I went for this patient for the Diebler-Miller keratoplasty. And this patient's story that he has a corneal infection. And after a long time of treatment for this corneal infection, the infection was treated and the ulcer healed, actually leaving behind a very extensive and a very deep corneal opacity. But when I went for pretreating keratoplasty, upon the impression that this deep corneal opacity should include the descemet membrane. But in every case of keratoplasty, I'm starting as DALK in every case. But in this patient, when I started with Diebler-Miller with very successful air bubble, I found finally that the descemet is completely intact and not included in the opacity, fortunately. Then I bought the graft, and 3 days, and 3 days after surgery, 1 week after surgery, I found that there is this picture you see on the right side in this screen, which there is a corneal edema not responding properly to the old treatments, And also I found that there's something behind the cornea, which was mistaken by one of my colleagues as a reaction, but it was not reaction. I found that it's related to the back of the cornea moving and dancing with the movement of the eye. So I suspect something related to the back of the cornea. And when examined this patient with the anterior segment OCT, I found that this is the graft and this is the descent. There is partial or subtotal descent detachment, or to be more expressive, descent gapping. It's not detachment because the descent was intact completely around, and I photographed, but there is no coaptation between the descent and the new graft. So I thought to do a repositioning of this descent using a big air bubble, and this is what I, as you see in this video. But sorry for the bad resolution. I captured it with my mobile. There was no facility to do another way. Here, this is the injection. Again, I entered from the side by the OCT guided. Enter from the side where the descent is attached, and put my needle, insert my needle directly to the iris, and then I injected a very big air bubble. Tension is very high, so I gave my patient some drugs to lower the intraocular pressure. And the surprise is here. This is before injection, and this is 3 days after injection. Look here, you will find that the descent is totally attached to the back of the cornea, and now it's hugging the and intimate now to the graft, the new graft, with improvement of the vision, the clarity of the cornea, and the patient came relaxed and more cheerful and smiling on the follow-up. The third part of the corneal surgeries which is aided by the MS-39 is the intracorneal ring segment implantation planning. Actually, from our experience, we can plan for the arc length of the intracorneal ring segment, also the site of the incision, the turn, the position regarding the cone, but also this device offers you a plan, a help in the plan to implant the IOL. You will define the IL. Here, if you look at the right side of this picture, you'll find that the optical zone is 5 millimeter. The intracorneal ring segment arc length is 210. The intracorneal ring segment thickness, sorry, it's a mistake here. It's 250. Also, the bisecting line is 315, and the incision angle is 75. So it plans and it helps you to plan the site of the incision and the track of the intracorneal ring segment to flatten the cone, because it gives you an accurate calculation for the steepest axis and the flattest axis and the path of the intracorneal ring segment to get the best result after that. Here also there are different captures for the anterior segment OCT part of the MS-39. You will find how it helps you. How does it help you to know the thickness of the cornea? Here you will find that there's in the picture down left how the cornea is very thin, and you can go for keratoplasty or by penetrating or by the DALC. It helps you to define the depth and the thickness and the vulnerability of this cornea. There are descent tears, or in 360 degrees studying. Also here down right, you will find the depth and the effectiveness of the intracorneal ring segment implantation. Also, it helps you to define if there is absolute thinning just beneath the intracorneal ring segment, or there is perforation of the cornea, which may happen in some cases with the miscalculation of the depth during implantation. Sorry, so the cornea section, the AC depth is a very crucial issue, as you know, in patients going to do or to undergo phakic IOL implantation. AC depth, accurate AC depth by the OCT, or also the angle measurements in glaucoma, and as I said, white to white, which is customized white to white. Also the lens vault, which is very important, the posterior chamber IOLs. If you are going to do ICL, you have to know the lens vault and the space in the posterior chamber, and if it's a good and proper space, or you may expect problems after implantation of the ICL. What about glaucoma surgeons? Are they benefiting or having a benefit from this device? Actually, yes. Because this device offers you a glaucoma summary by measurements of the angle all over the circumference of the eye, and if there is adhesion or narrowing of the angle, open angle or angle occluder, and also the behavior of the iris, if there is normal iris or plateau iris. Also here, you will find that this device helps you to measure the corrected IOP, which you may have it by the aura. By calculation of the central corneal thickness, and in relation to the given intraocular pressure by the Goldmann applanation. So you will put the applanation here, which was 13 in this patient. This patient is a glaucomatous one, and underwent LASIK surgery 7 years ago before coming to me with other colleague. So when I measured the IOP, it was 13 millimeter of mercury by the applanation, by the Goldmann applanation. But when I calculated this pressure on this shaft formula, giving the IOP corrected to be 19 millimeter mercury. And it's a very important point to know, because this patient is on 3 drugs, and the C ratio is 0.9 in both eyes, because this patient was not discovered prior to surgery because of the lack of the proper examination, the proper preparation before going for LASIK surgery. But anyway, it's not our problem here, but this patient is on 3 drugs and mistakenly or incorrectly measured by the Goldmann to be 13, and you will be comfortable for this patient, and you will continue with your drugs. But after being on 3 drugs, and on the Goldmann is 13, and by the corrected IOP measurement is 19, so it's not optimal for this patient. Either to change drugs or to go for surgery to protect the remaining part of the optic nerve from damage. So it's very helpful in glaucoma patients. Finally, the details of cornea screening software in this device. As you see, all the maps with the pattern deviation from the normal to know finally by these diagrams and maps if this patient is going to be normal in the normal range on the normal side or suspicious side, or to be sure from your diagnosis, this patient, for example, is a keratoconic patient. Away from the all maps, look here at the applanated cornea. I will show you in the next slide how this applanated cornea, which is the 3 millimeter of the central 3 millimeter of the cornea, is applanated and magnified to see the corneal layers and to see the posterior elevation by your naked eyes without with no need for the microscope or even for figures. Look here, you will find that the posterior surface is irregular. It's not smoothly.
خلاص خلصوا الفاينالي دي الكلمة الوحيدة اللي فهمت.
Please.
The microphone, please. Hello. Hello.
Keratoconus. So this keratoconus classification is also graded using the Bellin grading of keratoconus A, B, C, D. Okay. Here we will discuss again the ablinated corneal section because it's very helpful in diagnosis. I can rely on it to diagnose if this patient is keratoconus or not, in correlation to the figures and numbers you will see in the other maps. Look here, you will find that the ablinated cornea on your left side showing normal, smooth, and regular posterior surface of the cornea up and down, OD and OS. But here in the middle, you will see that the back of the cornea is very irregular, showing this posterior high point of the posterior elevation where there is a forward a protrusion of the back of the cornea, which is one of the signs of the posterior keratoconus or the keratoconus itself as a posterior disease. Here I can also study the tissue integrity of the stroma. If there is opacity, if there is inflammation, even by the haze or keratocite activity. So it's very important point to know and to use in different situations of the corneal disorders. Finally, corneal mapping using the spectral domain OCT, total corneal thickness, which is the pachymetry map, also the epithelial thickness, also the stromal thickness. And let me show the most important point to focus on in this device, which is the epithelial mapping, which is one of the new tools to diagnose the early keratoconus and to be sure from your diagnosis. Let's go directly. First, I have to show first the epithelial mapping from this theory of the early keratoconus, which is the epithelial behavior shown by the Dan Reinstein. And he said that the normal epithelium is all around with a normal homogeneous thickness. As you see in the normal part of this diagram, in keratoconus, there is posterior elevation, which is forward or protrusion of the back of the cornea, pushing the anterior corneal, the anterior surface of the stroma going in front, going forward. But this cone or this apex of the cone is usually masked by the epithelial changes. As you see here, the part in front of the cone is very thin, while the surrounding part is very thick. So the thinning of the epithelium will mask the protrusion of the cone. So the early keratoconus can't be shown directly on the surface because it's masked by the epithelial changes. And from this point, they discovered that the epithelial changes could be a sign for keratoconus at early stages before going to be obvious and frank keratoconus. Also, the thickening in the last part, as you see on the most right diagram, thickening in the epithelium may explain the steepening of the anterior surface, steepening in the topography, no back changes, to be sure that this is not a keratoconus. So this is normal epithelial map with homogeneous configuration, almost equal thicknesses all around the central area, and normally epithelium is thicker in the center than in the periphery, which is the reverse of the total pachymetry. But the abnormal maps could be blue, and this blue color is blue, but it's red. It's red in the sign of danger, as you see here, the do not sign, and you are seeing here the sign of danger. Here you have to stop, because the donut formation, which means thinning surrounded by thickening, it's a sure sign of cryoconus, especially if it coincides to thinnest location in the pachymetry map, also steepening in the anterior curvature map, also high point of elevation, anterior and posterior elevation maps. So if you have a thinning in the corneal epithelial map surrounded by thickening, as you see, which is marked by this red circle around this blue island, if this point is similar to steep point in the topography, thin point in the pachymetry map, and high points in the elevation maps, either anterior or posterior, so it's a sure sign of cryoconus, and you have to stop thinking in refractive surgery, and you have to think how to manage this case of cryoconus according to the stage. Also here, you will find the other abnormal map, which is red in color, but blue in the meaning, or green in the meaning, actually, which means a good thing. It's red in color, but good in nature. Red sign in the epithelial map means thickening, and thickening is a good, not like thin. So thickness will be very significant, assuring sign if coinciding to steep area in topography, coinciding to the thinnest location in the pachymetry map, also in cases of regaining errors after laser vision correction. So the question here, I will repeat it many times. Does it change the map? I mean, MS39, does it change the map or not? In my opinion, from my practice, yes, it's actually changing the map all the time. Before going to the cryoconus and the suspicion, I will talk briefly about this issue. The epithelial map helps you for the perfect and accurate correction if you are going to do trans-PRK, because actually we are empirically putting the epithelial thickness in our machines without having an accurate epithelial thickness measurement. So in the trans-PRK, you are removing the epithelium according to the thickness. If you put lower thickness than normal or higher than normal in your case, you will get under correction or over correction. So the epithelial thickness map, it should be should be obtained in cases of trans-PRK to get a good and accurate correction. Also, it helps you changing the map in the accurate diagnosis. So you'll be confident decision, you will get confident decision, and you will get honest guide. How it's very helpful in the diagnosis of cryoconus, especially the early stages of cryoconus. If you have this topography with this inferior steepening, look here, it's all around green with this orange color, orange and red color. This is an indicator for steepening, which is central and inferior. Usually it's significant, it's when inferior than superior, but here, stop, wait, or go. Let's simplify it in these diagrams. If you have epithelial map with thinning all over the steep part, you have to stop. It's cryoconus. If you have a somewhat darker green, which is insignificant difference, you can go, but it's better to wait, especially in the young patients with no contact lens wear, with no rubbing. You have to wait, or it's better to wait for follow-up after some time. But if you have this red sign, which is thickening with marked difference between the epithelial thickness above and below regarding this steep part, you can go, and please go. I will show the epithelial map role in detection of the early keratoconus and how it makes you much safer in deciding about refractive surgery. I will show them in some clinical cases. Case 1, this is the pentacam for this patient. Please look at this pentacam. Do you see any suspicious points in this pentacam? If you look at the topography, there is very mild skewing. The difference between the superior and inferior points are less than 1, or actually it's 1.1, which is still less than 1.5, so it's still not it's still accepted. I mean, at the pachymetry map, there's a deviation of the y coordinate from the center of minus 0.7. It's the only point to be suspicious. If you look at the anterior and the posterior elevation point, they are still within normal range. They are not beyond 20 plus 22. Especially in the central part, there is plus 15, plus 13, plus 20. So this patient, I will be uncomfortable about this patient, but I cannot say this patient is keratoconic. I can go for PRK with small errors. I don't know what about you. I'm talking about my sense. Here, the Bellin-Ambrosio enhanced ectasia, and the deviation here is less than 2. It's 1.6, so it's somewhat suspicious, but I'm not sure till now about this patient. I cannot say it's keratoconic, but let's see together this epithelial mapping for this patient. Here, I found the surprise. It is donut. There is donut formation here above the point, above the somewhat suspicious ones of pentacam. There's thinning surrounded by thickening, so it's a sure sign of keratoconus. So no way to think about refractive surgery in such patient. And this example shows all of you, how the epithelial mapping could be decisive to help you in decision. Another case, the same theme, somewhat high points in the elevation, but still within the normal range with a very good pachymetry map and anterior surface. The deviation in the Bellin and the bad D is very very normal. But here, the epithelial mapping shows a part of thinning. Here, the point is 50 micrometer, while the surrounding is going to be 56. So the difference is like that. I said that somewhat darker, but not red, not blue. So you have to suspect this patient and you have to wait and follow up, and don't go for any. This is thin and this is thick point. So how does epithelial mapping help you to be more confident in diagnosis of the refractive decision? I will show some cases from our center, how we dealt with. Do you feel safe? Do laser vision correction or not? Actually, look here at the pachymetry map. It's normal but thin, but no dome shape, no significant deviation in the y coordinate. Also, there is no big difference between the superior and inferior points in the pachymetry map. Look here at the tangential anterior curvature. There is superior steepening. Superior steepening is almost less suspicious than the inferior steepening, because I one of the surgeons who don't believe in superior keratoconus, but I will tell you about superior keratoectasia due to other pathological issues in the cornea. But here, the inferior part is good. The back curvature down is very good. The elevation in the anterior and posterior elevation maps are very well. So it is thin cornea in the pachymetry map, but look at the epithelial map to find that the central part is 55, 56, 57, 54, and the superior point, which is coinciding to the superior steepening, is 59. So it is thicker than the center. I don't have any problem with the center, so it's the normal. But the superior steep part is associated with thickening, so it's a hyperplasia of the epithelium in this part, and I can go for refractive surgery very comfortably and confidently. I'm just noting these two parts to know about. Another case here, if you look at the tangential curvature, you will find the central 3 millimeter, the superior point is 45.5, and the inferior point is 47.7. The difference is more than 2 diopters, which is very important and very significant to think about. But if you look at the back, you will find that there is inferior steepening in the back of the cornea. The superior point is -6.4, while the inferior point in the same circle is -7.0. So it's going to be protrude anteriorly with good back elevation in the same point of curvature and anterior elevation as well. But look here at the bachymetry map. It's again thin cornea with the y coordinate is around -0.6, still within the range. But here, if you look here at the epithelial mapping, at the central point or at the inferior point of the steepening, you will find that there is thinning. It's 55, but above at the superior point is 61. So it's suspicious. It's suspicious based upon the epithelial mapping, also on the back curvature, not only the anterior curvature. Look here at the circles. Both of them can diagnose the keratoconus in the very early stage. And I'm sure that if these patients were captured by the Pentacam, I expect we would find a very different maps, which will be like normal. Here, more and more cases. Here, you look at this case. The central part, superior point 42. The lower point is 42.9, still within the normal range. But look at the back curvature just below it. The superior point is -5.9, the inferior point -6.2. So there is a difference between the superior and the inferior point, which coincides to anterior surface as well. Look here at the epithelial mapping. There is insignificant thinning or difference, but it's like the yellow sign. You have to wait and follow up. Again, the epithelial mapping is very helpful tool to define if this patient is suspicious or not. Don't pay attention to the anterior curvature steepening with no sign, with no coinciding sign on the epithelium. Look at this patient screening. The back is good. The elevation, the posterior elevation on the back of cornea is very good and very smoothly moving, as you see. There's some issues regarding the corneal thickness. It's 459, which is a very thin cornea. So the device in its interpretation will mark a red sign on the thickness and will mark a yellow sign on the difference between the superior and the inferior points, and also will sign a yellow sign at the epithelial thickness difference. So classification of this patient is normal, but with a mild suspicion to follow up. Look at this, to do laser vision correction or not. In such patient, the thickness minimum is 477. The key reading is almost within the accepted and good range, but look here at the topography. The topography is very well, no problem at all. The anterior elevation and the posterior elevation is very well. But look here at the tangential posterior curvature. you will find that there is a difference between the superior and the inferior point, and the steep point in the inferior part of the posterior curvature is coinciding to thinning in the epithelial thickness map above on your right side, as you see. So this patient is suspicious. Actually, this patient is around 48 years old, and he came to do laser vision correction with me, and I advised him, don't do any laser vision correction this time. You have to follow up with me to know if you are progressing or not, to do cross-linking if you are progressing, despite being more than 45, because keratoconus doesn't respect the rules of the age. I reported cases of advanced or progressive keratoconus after the age of 45 and 50s. Another patient, look at this patient for both eyes. You will find that there is inferior steepening with a good back, with a good elevation maps, with a very good bachymetry map, with thinnest location of 515 micrometer, and the difference between the epithelial thickness in the different points are accepted. But finally, what about this inferior steepening? It's very significant. It's a highly significant. But look at the back. The back is smooth and equal. Look at the elevation, is smooth and equal. But look finally at the epithelial thickness map. This is the anterior and the posterior curvature map. Okay, and here is the pachymetry map and the epithelial map. You will find that the thin part of the pachymetry is coinciding to a thick part of the epithelium. So I have gone for refractive surgery in this patient with no worry. Finally, I think it will be the last. What about the post-LASIK with the MS-39? The era of the epithelial mapping actually changed my mind about the redo cases, especially if you have done a highly myopic patient after many years, 5, 6, 7 years. This patient may come to you again with residual error or regained or regressed error. So you will be worried about if there is ectasia or another cause for regression of the eye, or something related to the cornea, or what. So when I capture these patients with the MS-39, I found that everything is okay about the topography, about the back, about the elevation, about the corneal pachymetry. But here, look here down left to the epithelial map to find this dome-shaped orange sign, which is a hyperplasia of the epithelium. So this patient, the regression is related to overhealing of the bed and overhealing of the epithelium to compensate for the ablated part of the central cornea. So the main cause for regression and the regaining errors after LASIK is the chronic and the progressive hyperplasia of the epithelium during these years. Or all over the past years. So the decision in such case will be confidently and comfortably redo using redo by PRK with a mitomycin up to 1 minute. Application of the mitomycin for up to 1 minute to decrease the activity of the epithelial cells and to decrease the incidence of hyperplasia. Putting in your consideration the thickness of the epithelium itself, and it will depend upon to overcorrect or undercorrect, will be based upon the desired ablation zone. The optical zone 6 millimeter or 6.5 or 5.8, you will calculate according to the pupil diameter and the flap diameter. And don't forget to measure the flap thickness by the anterior segment OCT section to know the depth allowed for ablation. So it's very helpful to know about, and also it will help you planning for redo after that. Also, the post-LASIK ectasia. I found this case 3 weeks ago. He came with deterioration of vision 7 years after doing LASIK surgery with one of our colleagues in Upper Egypt. So when I examined the cornea with the MS39, I found this issues. Look here at the back elevation, the posterior elevation here down right. You will find that there is a suspicious point, still plus 12, but it is I think it's alarming point. Look here at the back curvature. Look here at the back curvature. You will find that there is inferior steepening at the same point of the high elevation. The back elevation is still plus 12, but I think it's progressing from plus 6 to plus 10, plus 12, and going to be more and more. So the back elevation, which is not affected by the laser ablation, is changing. So at the posterior elevation, also at the same point. Look here, actually, the epithelial thickness map will help you as well. There is thinning in the epithelial mapping here at the same point of the back curvature and back elevation high points. But about the pachymetry map and topography, I know that there is irregularity in the topography, but in post-LASIK we cannot control. We cannot judge with the anterior surface because of the decentered ablation, the irregular ablation, and the other causes. But we will rely upon the back elevation, the back curvature maps, also the epithelial thickness maps in such patients, because epithelial behavior will move according to the protrusion of the stroma, the corneal stroma. And this patient showed a post-LASIK ectasia in the right eye, but the left eye was very well. So I went for cross-linking for both eyes. Let me announce today for our sign, our report about this sign by Dr. Ahmed Orma and Hussam Ziada, and I called it Orma Ziada sign, which is the Turkish Sofi dancer sign. Look here, the inferior steepening here is showing like the part of this dancer sign. So when you see this sign, it's not keratoconus, even obvious and significant steepening, but you have to think about anything other than the keratoconus, because it's not the regular pattern of the keratoconus. Keratoconus, in my notices, is a central and inferior, but it's not totally inferior. So this Orma Ziada sign is inferior steepening with double wavy contour without superior limb, like that of the Turkish Sofi dancer cloth. It's mild, moderate, or severe according to SOPOT, in your mind, the differential diagnosis. But actually, the epithelial mapping will help you to diagnose, because you will find that the epithelial mapping will show thickening all over this part, not thinning, to tell you about the actual cause for this steepening. In this patient was contact lens wearer. So when I asked her to discontinue the contact lens for 1 week and come to me again, actually this patient was captured with Pentacam in other place. And 10 days after discontinuation of the contact lens, the maps be like that. It is a surprising change. Look here, it's totally different, just 10 days apart. almost equal, completely normal on the right side, but completely abnormal on the left side. So don't be hurry. Actually, this patient was sent for us, diagnosed as keratoconus, and please, Prof, go for intracorneal ring or cross-linking as you see. I asked it for something. Contact lens wearer, yes, okay. Stop it and come again to get this capture. Please don't be hurry for diagnosis and put in your consideration the eye wrapping and the contact lens wearing. So this patient also was diagnosed as post-LASIK ectasia. With this map, but look at the back. There's no changes in the back at all. The main or the purpose of showing these cases, they are sent to me by my colleagues to take my opinion, and I asked them actually to send these patients for epithelial mapping, but they didn't do. But actually, I'd like to share with you these issues and the experiences together. This inferior steepening in this part with anterior elevation, but the back is totally normal. The back is totally normal. So there's no ectasia without back changes. There's no ectasia without back curvature changes or posterior elevation changes. The bachymetry is very well. And here the point is thick in front of the steep part. So the bachymetry map is thickening. There's thickening in the bachymetry map in front of the steep area with high anterior elevation, but very normal posterior elevation. So think in another thing than the ectasia or keratoconus. This patient, I think there is a cause for corneal edema or epithelial hyperplasia in this part because the bachymetry map is higher. And so this is the curvature, the sagittal curvature with normal back and normal bachymetry. So don't look at TKC or these indices because it's artificial intelligence depending upon figures, but you have to be more intelligent than the artificial intelligence. To conclude, the MS-39 is an amazing device, and the MS-39 is offering for all of us. Actually, I'm enjoying the life with my baby here in my center. I'm doing all my cases with ease, with comfort, with confidence, and alhamdulillah, nothing and no worry no worry about any decision about any case. And please put in your consideration the epithelial mapping for your cases prior to surgery. It's very important to consider the epithelial mapping as one of the routine investigation before going to do any refractive surgery. Is very helpful. Don't be hurried to diagnose keratoconus in early stages or in concomitant signs in the back elevation, in the anterior elevation, in the topography, in the bachymetry map. No point alone is enough to diagnose. We have to correlate all the parts together, also with the other tools. And I haven't to forget considering also the corneal biomechanical studies by the Aura or Corvus to be added to the tools which help you diagnose the keratoconus and be comfortable about your patients, or to be worried about him. So it could be a very early indicator before having posterior surface changes detectable in the bad D. So both devices together will help you. This is a new theory to be considered. Epithelial mapping should be available in the oral refractive surgery, as I said. And thank you so much for your attention.
So thank you so much, Professor Ziada. Very helpful meeting, a presentation about epithelium and issue about regarding the cornea. There is someone that they want to make some question. Have some question for the doctor, from the prof.
My pleasure, Marco. I'm sorry for the long time. I know that I exceeded my my expected time, but I didn't tell all of you about what I know about this device and about my love to this device.
But it was very, very interesting and is run very well. So don't worry for the time that you talk, because it's very precious. And we have not talked also for the IOL calculator and other interesting things of this device, that it can calculate the IOL with the ray tracing. So that it was very focused in laser and in epithelium importance. And it was very, very nice, and is run very well.
Yeah, okay. I'm waiting for the new. I know that you have now a new innovations and the new updates about the software of this device. I was talking to Versace about it. I'm waiting to meet soon in ISCRS or other events to know about. I'd like to thank you so much, and to thank also my professors, my colleagues, who tolerated all that long time. And if you have any question, I will be happy to answer.
Okay, there is some question.
Yes, Saeed Az-Zahrani. Dr. Saeed Zahrani, if the new device has an axial length calculator. I was talking to Versace about that, because
Yes.
the biometry, all the biometry data available in this device, except unfortunately the axial length calculation. So I need a scan, but they are going to update this device about that to add a posterior OCT to measure the axial length calculator.
Yes, it will be ready soon.
Yeah. Okay. The engineer which is working on it, promised us so that it will be very soon. And in my opinion, it should be to complete the combination.
Yes. Another question: is possible then the measure or retrotation of toric IOL post-surgery? It is possible, but you need the aberrometer, the total aberrometer connected to it, because you can see.
But it can, Marco. Yeah, it can do. It can do. I examined one of my patients after surgery with it to find the axis of the IL and the axis of the cornea. It draws diagrammatically the IL position and the expected position preoperatively, and finally it correlates the topographic or the corneal astigmatism with the total astigmatism to know if it's coinciding to the axis or not, because it's one of the anterior segment measurements it can do, and it's still in the anterior segment. This device actually can measure from the corneal surface back to the lens, and the implanted IOL is still in this range, so it can do that. But it will be much better if you have the aberrometer, as Marco told us now.
Yes.
The plan to place ICR in this device meet your decision as refractive expert. Yeah, more or less, yes. It depends upon the nomograms, but you know that we have some issues or some adjustments about over the nomogram regarding to the clinical experience, but actually for the, let me say for the beginners, it's very, very helpful. It plans it according to the what nomogram in this device, but it's very helpful. Thank you, my dear Professor Hosni Hassan. Thank you so much. It's our pleasure all the time to see you, sir, and to hear that from you, your and continuous support for all of us. May Allah bless you, sir. Thank you for the precious, interesting illustration about that fantastic device. Thank you, Dr. Hisham Saadani. Okay, I think we finished the question, Marco.
Yes. Yes.
Okay.
I think yes. If there is not other questions, I would say thanks for your time, the Professor Ziada. I would like to thank all of you for attending at this. And there is another message.
Excuse me, I have a question, Dr. Hisham Saadani. Okay, I'd like to welcome Engineer Aras Muslim. You're welcome, brother. Excuse me, I have a question. How can we, as a beginner ophthalmologist, learn how to use it? It's very easy, Dr. Hisham. You can come to my center and spend some time with us here, and you will know everything about this device. If you are talking or you are asking about how to use it, it's an operation like operator. I'm doing myself, also the operator here in Ziada Eye Center, they are doing either optometrist or my assistant from the ophthalmologist. They are doing it very easily. But if you are asking about how to interpret it, or to how to read it, is very easy to just to see some cases, as I have shown now, to know the keywords of reading the maps.
Yeah. Yes,
Okay.
because one of the important things that we have to say that many of these maps that we have seen they are taken with the one shoot, only one shoot. So you have not to manage a lot with the machine, but you have in the topography one shoot, you have all information and are collected in different summary. And then you can take the section in the section mood where you can investigate where there is some problems. So it is very easy to use this machine.
Yes, Marco. Welcome, Dr. Khalid Basha. Thank you so much. Dr. Isra, the manager of this device. You know, a very good relation with this device. Dr. Isra, thank you so much. You are a very good operator on it. Thank you, Marco. And I think it's the time of saying thank you and goodbye.
Thank you, you too. Thank you for your time. And thank you, all of you again, for attending at this meeting. And I hope to see you soon in Barcelona for XRs or for someone where. And thank you for your time. Thank you a lot.
Bye-bye.
Have a nice night.
Have a
Good night. Bye-bye. Bye.
Bye-bye.
Bye-bye.
Bye-bye.